I have the distinct pleasure of introducing our speaker today, Dr. Andrew Steptoe. I was just telling Andrew that we've collaborated now in a number of projects over the last decade, and I don't believe we've actually spent much time in person. So I hope, Andrew, that will change and we'll get a chance to interact in person one day soon. So a little bit about our speaker. Dr. Steptoe is a distinguished professor of psychology. He's a world-renowned expert in the fields of psychobiology, health psychology, and social epidemiology at the University of College London, where he is professor of psychology and epidemiology and head of the research department of behavioral sciences and health. He is the past president of the International Society for Behavioral Medicine. He's a fellow of the Academy of Medical Sciences, the Academy of Social Sciences, and the Royal Society of Biology. He was a founding editor of the British Journal of Health Psychology, and he currently directs the English Longitudinal Study of Aging, ELSA, with over 700 peer-reviewed articles and 20 books and edited volumes to his name. Dr. Steptoe has been a true, I would say, luminary in the field of psychology and a leading voice in the global conversation on the intersection of psychology, health, and public policy. And so we're really honored to have him here today to share with us his insights and expertise. So with that, Andrew, if you're ready, please share with us your slides and take it away.
Thank you very much. Can I check that everyone can see that?
Yes.
Great. Well, thank you very much, Anthony. Very kind of you to invite me to give this presentation and also for your kind introduction. And I'm delighted to be involved in a very peripheral way in your new Center for Integrative Developmental Science. It sounds like a very exciting initiative, and I do hope that it will take off in a kind of interdisciplinary way that you're hoping that it'll achieve. You asked me to talk about the work that we've been doing during the COVID pandemic, and that kind of covers both the epidemiology side of my work and also psychology, so I'm very pleased to do that. I'm going to run through quite a few studies and analyses we've been doing in this area, but I think there'll be a recording available if people want to get back to anything later on. So let me kick off with just reminding you, it seems a long time ago now, what the situation was, but this slide here shows data from the beginning of the pandemic in March 2020 up until late 2021, showing in this case the number of confirmed daily cases in the United Kingdom in the sort of dark, in the lighter color, and in the US, showing a very similar profile actually in the two countries. Obviously, there weren't that many confirmed cases in March, April, May 2020 because we didn't have any testing, and so there was nothing available for that. But later on, in particular towards the end of 2020, there was this big peak. And then, of course, what we also saw in both countries was really devastating levels of mortality in the early parts of the pandemic. So this shows the 7-day averages of deaths per million people. And what you can see is that the UK actually did rather worse than the US, though I think in both countries, I don't think either country would be at all proud of its record here, with large peaks early on in the pandemic, and then another major peak at the end of 2020, beginning of 2021. And then, of course, vaccines began to be used more, and in the UK, vaccine rollout was very rapid, and so levels of mortality went down rather quickly, whereas in the US, there was an additional mortality peak in the end of 2021. So it's against that background that I'm going to be talking about the sort of health and well-being aspects of the work that we've been doing. And what I'd like to do in this presentation is cover these issues here, tell you something about our work on trajectories of psychological well-being over this period, to focus on two particular issues, which are time use and also psychological aspects of long COVID, which is becoming increasingly important. Then to say something about how we might, as it were, leverage the pandemic for stress research, and then talk about some more recent analyses, which I am doing very slowly on resilience and living a worthwhile life during the pandemic. And I'm going to be drawing on two sets of data that I was involved with. One is something called the UCL COVID Social Study, which was being run by my colleague Daisy Fancourt, and I was the co-I on that. And the other is the specific components of the English Longitudinal Study of Aging, ELSA, the work that we did during the COVID period. So the COVID-19 social study was quite a large study, and this shows you the outline of the study. This was one of the many online studies which started very early on. This one actually started just at the time of the first lockdown in the UK, with weekly assessments and then moving on to monthly assessments. And it went on for 2 years, so we finished in March 2022. It was a large study with more than 70,000 people involved, and at any one time, we had 20, 30 or 40,000 people involved in the study. So quite a large set of longitudinal data. And it was used to look at mental health, which I'm going to be telling you about. But in addition, it was used very much in this country for monitoring things like the extent to which people were following government regulations, how confident they were in the government's handling of things, in health behaviors, then in attitudes to vaccination and all sorts of other things. So the study was actually used quite extensively by the health policy teams here in the UK, and indeed in central government as well, and the Prime Minister's teams and so on were all looking at our data to see what was going on. It's an online survey, so it's not representative, and so the analyses were weighted using inverse probability weightings to try to bring the data into line with the distribution of people in the English population in relation to these characteristics that I've laid out in the slide. And then also there was quite an extensive qualitative component to this study, which I'm not going to talk about. So let me show you, first of all, the broad profile of measures of depression using the PHQ-9 and anxiety using the GAD-7 from the beginning of the study at the time, second half of March 2020, when the lockdown started in this country, right through until March 2022. So the blue line is the depression scores and the orange line are the anxiety scores. There are a number of other lines on this graph which we needn't worry about too much, but just to give you an indication, there's the plot of the number of deaths per day, which is the line towards the bottom of the screen. And up at the top is something called the stringency index, which is an international index essentially about government policies at different phases of the pandemic to do with the stringency of lockdowns, of workplaces closing, of schools closing and things like that, which varied quite a lot. What you can see by and large is that anxiety and depression were highest right at the beginning of the pandemic and then went down quite quickly over the summer of 2020 and then increased during the winter time, which was really coinciding with the second major peak in this country, then declined again later on and then increased during towards the end of 2021 as well. And these are elevated compared with what you might expect, though they're not hugely elevated, but they definitely are elevated. This slide here shows a slightly more kind of sophisticated analysis. This is one which was published a couple of years ago now, showing the patterns over the first 20 months of the pandemic, just to illustrate two important issues. First, on the left-hand side, you can see the gender differences. So there are higher levels of depression and anxiety among women than men, though the groups converged to some extent as time went by. And then on the right-hand side is the age pattern that we saw in our study. These analyses are around 45,000 people. And what we see is a very clear relationship between age and the profiles, with younger people showing higher rates early on in the pandemic, declining fairly rapidly, and so the age groups are tending to converge. Apart from anxiety and depression, there's also other aspects of mental well-being which were impaired. And one interesting one, I think, is to do with abuse and self-harm. So this slide here is using analysis early on in the pandemic again of, as you can see, 44,000 people in this particular data analysis quite early in the pandemic. And the way we've divided this out is actually in terms of income, because as well as gender, there's also a pronounced socioeconomic differential in the way in which people responded to the pandemic. So you can see that people who are earning fewer than £30,000, which is about $40,000 or $38,000, were more likely to be reporting psychological abuse and physical abuse, self-harm thoughts and so forth, than the more affluent people. The levels of self-harm thoughts are really quite high during this period, which is disturbing, although the self-harm behaviors were not so high, but still of concern. So this is another aspect of people's experience that we were able to look at. I guess one of the aspects that in popular culture and in sort of the newspapers and in media that people were particularly concerned about was loneliness and isolation. And it's not surprising because of all these features that were very prominent in the early phases of the pandemic. There were, first of all, various instructions in most countries, including the US and the UK, in terms of workplaces closing, schools and universities closing, and then all sorts of social activities being very limited. And this led to, obviously, social distancing and stay-at-home orders. And so quite a strong sense that this would be a very serious issue during the pandemic as it evolved. And as you probably know, the data on this have not actually been very striking. This, I think, very interesting review in American Psychologist last year was looking at quite a lot of different studies, looking at loneliness measured mostly with the UCLA scales, showing some variation between studies, some showing increases in loneliness, some showing very little change, but overall not an enormous increase in loneliness, as might have been expected under these circumstances. And this is certainly something that we also observed in our COVID social study. These data here are showing loneliness across the, I think this is across all nearly 2 years, in fact, with women in orange, these are adults, and men in the bluish color. And this is using the UCLA short form. So the scale ranges from 3 as the lowest to 9 is the highest. So these scores are not particularly high. They're slightly higher than one might have expected, but not very strikingly high, and not showing a huge amount of variation over this 2-year time period. I'm not quite sure what was going on towards the summer of 2021, where there's a sort of jagged sawtooth pattern, but I think that's just a glitch in the data. So why might this be that these particular aspects were not being affected quite so much? I think Daisy Fancourt and I wrote a blog actually about this in the British Medical Journal, trying to characterize the experience during the pandemic compared with what we call normal isolation and loneliness. That is the sort of more generic kind of things that are present not only during the pandemic, but at other times as well. And there are really quite a lot of differences, I think, which might be accounting for the fact that there weren't more striking disruptions in these particular experiences. First of all, in sort of regular isolation loneliness, this is an individual experience and it's socially patterned, so it tends to be characteristic of certain more deprived groups, whereas for the pandemic, it was a worldwide experience and everyone was affected. During the pandemic, the experience was time limited. We knew it wasn't going to last forever, being put into these restrictive states, whereas for regular loneliness, it's often without, people can't see any end of that. And of course, when we think about isolation and loneliness in general, people actually have rather few contacts, and they also have this strong fear of missing out. They have the sense that other people are having a good time that they're not having. Whereas During the pandemic, that was not the case because no one was really doing anything, so there was not very much to miss out on. And there was unlimited remote contact as well. So I think these sort of reasons might be explaining why there wasn't a more striking difference. And then the other difference, of course, is that the very high level of illness risk present during the pandemic. So I think this is interesting because it makes one think about what are the causes of the distress during the pandemic and what are the really important things. Are they to do with the restrictions or are they to do with the infection risk? So we could divide out the challenges during the pandemic, I think, into those which are specifically related to infection, fear of serious illness and death, of course, for yourself and for your family and friends, the actual experience of death and of family and friends, the uncertainty of the whole thing, and then as time went by, the onset of long COVID. These things are very specifically to do with the infection risk. And then on the other hand, on the right-hand side are the various reactions one might get, which are really a result of the mitigation actions, the various actions which governments and local authorities took to try to reduce transmission, including obviously social distancing, but in particular things like closure of workplaces, the difficulty of access to provisions and healthcare, the impact there would be on schooling because of schools closing, the financial insecurity because of many types of work not being able to be done, household stress for people who are living in maybe cramped conditions, crowded conditions, and other factors of that sort. And in our COVID social study, we've tried to look at the extent to which people have been stressed by these different types of factor. And what's, I think, striking to me is that it's the COVID infection that has been really worrying people more than other things. And you might think that's kind of obvious, but in the kind of public discourse, that hasn't necessarily come out very prominently. But I think it does come out quite prominently in our data. These data here show, these are monthly measures from the beginning of the pandemic on the left-hand side through to January 2022 on the right-hand side. And this slide here shows the proportion of people who are reporting being stressed or very stressed by COVID, by unemployment, by other factors as well. And what you can see is that certainly for the first year or more than a year of the pandemic, it was the COVID stress which was the most prominent feature. So present in around half or even more than half of participants, although it went down over time. Whereas other things such as being concerned about finances was certainly present, but present in around sort of 30% of people, so a little bit lower. And then I put two others here, worry about unemployment and worry about getting food, both of which were much lower kind of level. And I think the stress related to the COVID infection itself is also reflected in an interesting analysis which we finished recently, and it's currently in press, so you can get it online if you're interested, which was doing a latent class analysis of the extent to which people stayed at home. So what this shows is results of weekly assessments where we ask people every week, how many days did they spend at home without going out? And so it goes obviously from 0 to 7 days a week, and starting at the beginning of the pandemic and then through to the middle of 2021, there were 4 classes which were identified here. Well, actually 3 classes which are identified, sorry. So the most common class, which was 43% of people, essentially didn't spend any more than 1 day on average at home without going out throughout the whole time period. So this was, as it were, the modal kind of response. Whereas you can see the orange group, these are people who spent 4 to 5 days a week without going out right the way through all these 18 months. So even though they might have been vaccinated and the levels of infection might have gone down, they still spent a lot of time at home without going out. That was, we found that in around a quarter of the people, 24%, and then what we call the adaptive profile, which is people starting off spending a lot of time at home, but then that diminishing, and then increasing again when there was during risk periods. That's in the green line. That was present in around 30% of people. So there is a substantial portion of the population who've remained really quite disrupted and impaired because of the pandemic, and right the way through this entire time period. And this home confined group, you wouldn't be surprised to know, were also people reporting higher levels of depression and anxiety. They typically were also people who had physical health problems and maybe mental health illness issues. So they might have felt more vulnerable. It was a more common profile among women and among people living alone. So I think all this does tend to suggest that the pandemic, it might be emphasizing the obvious, but the infection itself was pretty important. And some of the other mitigation things and the actions taken didn't really have such a major impact on the psychological profiles. Let me move on then to the next issue I wanted to talk about rather briefly, about time use and well-being, because it was an opportunity during the pandemic to have a think about whether we could identify particular ways in which people were spending their time and how that related to their well-being. And what we did, in fact, was a kind of a lagged analysis of data, again, fairly early on in the pandemic, in the early first couple of months of the pandemic. As you can see, this is analysis of 55,000 people. And what we were using here were weekly assessments of life satisfaction and weekly assessments of depression. And then we were also looking at people's time use. So we asked people every week how much time they spent doing different activities yesterday. This is a fixed effect analysis, so we're taking account of any within-person variability, and we're looking at lagged outcomes. So the interesting issue, I think, for me, is the extent to which time use on 1 week might predict either an increase or an impairment of well-being the week afterwards. And one can look at it obviously the other way around, and the paper does look at it both ways, but I think this is a more interesting way. Because what was found is that there were certain sorts of factors which were predicting increased life satisfaction on the following week. And the most striking ones were these: that was volunteering at least 30 minutes in the previous day. Those people the following week were reporting greater life satisfaction. If they were involved with gardening or working around their yards, that was also related to increased life satisfaction, and exercising as well. Whereas there were some other factors which were predicting reduced life satisfaction. Working was people were less happy later on, and following the COVID news, I think in a very sort of extensive way, was associated with lower life satisfaction the week after. So there might have been a case for not doing this. More time looking after children is a slightly odd one, but remember we're talking about here about how people were looking after their children compared with the previous week, and so they may have had extra childcare responsibilities, and that led to that was associated with later life satisfaction impairment. Let me move on then to the issue of long COVID and the psychological aspects of long COVID. This is something we've been looking at recently, and it's of course a pretty important issue now. And I think there's more and more research focus trying to look at this. And so I've shown you some of the analyses that we've done, but we're very actively working in this area at the moment. For those of you, just to remind you, the way long COVID is typically defined is symptoms that are present at least 12 weeks after the infection. So this could be symptoms having disappeared after the first infection and then recurring, but more commonly, in fact, the symptoms persist for at least 3 months. And there are multiple symptoms, which makes it very difficult to look at. These are some of the most prominent ones, things like fatigue, but also respiratory issues, cardiovascular symptoms, neurological symptoms, pain in various parts of the body, and also depression and anxiety. It's pretty well established that it's more likely in people who experience severe acute symptoms. So these people had worse COVID, when they were first infected, and also those people who had underlying health problems. So they might have some other comorbidities. Those people are more likely to develop long COVID. As you may know, this is now recognized as a disability under the Americans with Disabilities Act. We don't have anything like that in this country, so there's no particular protection, but it's now regarded as a kind of protected characteristic as far as in the US. But most troubling, I think, are the quite high levels. And these data here are from a large survey done by the CDC, reported in 2020, beginning of 2023, which were reporting 11% of people currently had long COVID and 17% had previously had long COVID. The levels are going down, and that's probably because, of course, the levels of infection are going down as well, and so fewer new cases are emerging. But nevertheless, this is a significant and probably a persisting kind of problem. We were interested in the issue of whether the acute symptoms, the acute trajectories, particularly in mental health, predicted the occurrence of long COVID. And using our COVID social study to try to get a handle on this. And the way we did this was to identify among the 60 to 70,000 people who produced regular data for us, those people who contracted infection. So a lot of the people in the study, of course, never got infected with COVID during the study period, but there were more than 3,000 who did. And of those people, 495 reported long COVID. So they had symptoms which were still present at 12 weeks following the original infection. And so what we did in this analysis was to do propensity score matching for those long COVID cases with what I'm calling short COVID cases. These are people who contracted infection but then were not reporting long COVID. And the propensity score matching, we managed that on 481 of these people, which is, I think, a pretty good rate. And you can see what things they were being matched on, all these socio-demographic characteristics, but also things like education, living conditions, that's how many people live in the household, their initial base mental and physical health, the amount of social contact they had with friends and family, and that kind of thing. So the analysis involves those two groups. And then what we did was growth curve modeling for depression and for anxiety, looking for up to 10 months before the onset of the acute symptoms, the initial COVID infection, and then 20 months afterwards, so as to try and see whether we could see any differences in those trajectories. Obviously, not everybody has data going back 10 months and forward 20 months, so some people only have a much smaller amount of data, but that can be handled in these growth curve modeling analyses. And this slide here shows, I think, some of the more interesting results from this study. On the left-hand side are the depressive symptoms, on the right-hand side are the anxiety symptoms. The future long COVID group is shown in the solid line, and the dotted line shows the short COVID, people who are infected, but then their infection was a one-off and they didn't develop long COVID. And you can see a couple of things here. First of all, that prior to infection, there's no difference in anxiety or depression symptoms. They really are very closely aligned. What is striking, however, is the acute impact of infection on these people. In particular, the long COVID group, the future long COVID group, show quite a large increase in depressive symptoms, a much larger one than the short COVID group. And they also show a somewhat bigger, though certainly a higher level of anxiety symptoms than the short COVID group. They then subside over the following months, but the long COVID group continue actually to have greater amount of psychological mental ill health than the short COVID group. So I think this is potentially quite interesting. It's something we're hoping to follow up in some other studies at the moment, but does tend to suggest that the kind of very first aspects of the infection might be important. What we can't do in this study is look, for example, at the intensity of the severity, if you like, of the infection, whether or not people were hospitalized or something like that. So it could be that some of this is a kind of to do with the magnitude, if you like, of the infection. But I think it's interesting nonetheless. So I've been talking so far about this COVID social study, which I would say is an example of one of many of the new ad hoc studies that were put in place at the start of the pandemic. And the characteristics of these studies is that they were rapidly mobilized, so they could be done pretty quickly. They were relatively inexpensive because they were online studies. There were repeated assessments. We did it weekly and then monthly, but other people did it at different types of rates. And there was trajectory analysis possible because of those repeat assessments. The limitations of these studies, which are fairly obvious, I think. First of all, these are selected samples. These are internet-based studies, so they tend to be more affluent or higher SES groups who are selected into these studies, and certainly people who are capable of doing this sort of thing online. Secondly, and importantly for psychologists and epidemiologists, the response rates are pretty uncertain. We just don't know how many people had a look at these studies but didn't end up doing them. And more importantly, in a way, there's no baseline comparison. So we can look at published norms for various scales, but we don't really have anything with which to compare the data. And so these are all, I think, important limitations of this kind of study. And this is why we and others have also been interested in using existing longitudinal studies where there's data which has been collected before. So we have a known sampling plane frame, and in the case of ELSA, the one I deal with, is population representative. We obviously have pre-pandemic measures, and importantly, there's an extensive amount of historical information about these people that we can have a look at. And so I'm going to spend the rest of the time that I have available telling you about what we've done using the English longitudinal study of aging as an example of this kind of approach. For those who don't know, ELSA is a representative sample, nationally representative sample of men and women aged 50 and over living in England in the community. And it started just over 20 years ago. And typically people are assessed every 2 years. It's a kind of multidisciplinary study, so involves a number of disciplines, including, importantly, economics, to look at various aspects of people's economic status, financial status as they grow older, sociology, clinical medicine, as well as epidemiology and psychology. What we did during the COVID period in 2020 was to carry out 2 sets of assessments, one in June and July, and the next one at the end of 2020. So not right at the beginning of the pandemic, but within about 3 months of the beginning, and then the end of 2020. This was funded by the Economic and Social Research Council here and also by the National Institute on Aging. And another important feature of our study compared with some is that it involved both online and telephone assessments. So most people actually did completed the survey online. Around 83% of people who did it completed it online. But we also made it possible for people who couldn't use online systems to have telephone assessments. And that's particularly important for a study of older people, of course, because they may not be able to manage the online side of it. So our response rates were pretty good, actually, 75%, both at the early and later time points during the pandemic. And the mean age during the pandemic was just under 68 in the sample that we were looking at. So what do the results show? Well, they show a fairly similar pattern to what's been found in other studies. I don't think there's a huge surprise here. Top left is showing the percentage of people who exceed our thresholds on the CESD that we use for measuring depression. So they're defined as people with high levels of depressive symptoms. So before COVID, that was assessments in 2018, 2019. The levels were around 12%. They went up to more than 20% early on in June, July of 2020. And then they went up even higher at the end of the 2020, up to 29, 30%. So This is important, I think, because it's showing that the responses weren't just acute responses, happening in the first few weeks and then everything settles down. Actually, the impairment got worse as time went by. This was accompanied by increases in poor quality of life, which is shown on the top right-hand side, some increases in loneliness, which I'll come back to in a moment, and also anxiety, which I don't think we measured particularly well. So I've only shown you 2 time points there. So what the study does suggest is that the psychological distress is indeed elevated compared with pre-pandemic levels. But you could argue, if you were being particular, is that you don't actually know that that's definitely the case, because you don't know what the time trend is of these experiences before the pandemic. It could be that everything was going up anyway, and so the pandemic was just overlaid on an increasing profile. But one of the advantages of looking at something like ELSA is that we can look right back over many years, as is shown in this slide here, showing the proportion of people with significant depressive symptoms going from 2008 right through to the pandemic period, shown in red. And what you can see is that there is no sign over this time period of a drastic increase over this decade. This really was a difference. This really was a definite response to the pandemic. These are overall average levels, and of course there are many differences in between people and what happened to them. But just before I come to that, let me just say something about loneliness. As I showed just a couple of slides ago, loneliness did increase, but in fact the loneliness increase is much smaller than many of the other measures that we use. So this slide here shows the change between pre-pandemic levels and early in the pandemic in panel A on the left-hand side, and later in the pandemic in panel B on the right-hand side, using standardized coefficients to make a direct comparison. And what you can see is that the increase in loneliness is substantially lower than the increase in depression, and it's substantially lower than the impairment in quality of life as well. So this fits in with what I was saying earlier about the loneliness side not being as striking during the pandemic as many people expected. As with other studies, there are some measures where we can see gender differences. So the gender differences were certainly present, particularly in our measure of poor quality of life. You can see in the middle panel here, this is showing the results from the pre-pandemic levels and then levels during the average, if you like, across the 2 pandemic assessments, with a larger increase among women than among men. And this is also true for loneliness, a larger increase among women. Depression, there wasn't really a significant interaction. So the depression levels are going up, but they're going up in both men and women. But the men have reporting lower levels of depression throughout. And then we also see differences related to socioeconomic status as well. We use these data to look at quite a number of other issues. You needn't worry about this slide, because if you have a look at the presentation later on, you can pick these up if you want. But these are various analyses we did looking at characteristics in relation to emotional distress and other aspects as well, where we've been looking not only at ELSA, but we've also been putting together other longitudinal studies in the UK to do a broader analysis of issues such as healthcare use and healthcare disruption. What I'd like to do, though, is to turn to the issue of what I'm calling leveraging the pandemic for stress research, which I think is an interesting thing to do, and it's something that we are hoping to do a bit more of in the future. What do I mean by that? What I mean is that we can think about the COVID pandemic, obviously very distressing, caused a lot of deaths. It's a worldwide trauma across the whole population. But we also know that depression, although depression, anxiety, and mental health got worse, many people didn't respond very much. And this is shown in a number of studies. And most recently, there's been a meta-analysis published in the British Medical Journal only a couple of weeks ago, which suggested that the increases were relatively small on average, which is sort of what I've shown already. And I think we could argue that that's fairly typical of potential traumas. If you think about the work by George Bonanno and others of potential traumas of a whole range of types, a lot of people are not showing very much reaction, sometimes called a resilient pattern as being a kind of modal pattern. Although there's disagreement about exactly the proportion of people who aren't reacting, it's still quite a substantial number. And this then gives the opportunity to study kind of stress diathesis interactions, the extent to which the exposure to stress leads to different responses depending on background characteristics. And we've been looking at this in a couple of analyses so far, but I hope we'll be able to do more of this. The first one I wanted to describe to you was an analysis we did looking at biomarkers pre-pandemic and whether biomarkers assessed before the pandemic predicted emotional responses during the pandemic. So we can look at this controlling, of course, for the pre-pandemic levels of mental health as well. And the first analysis we did in this area, I suppose, is fairly obvious. We looked at inflammation and depression. It's fairly obvious because, as many of you will know, there's a large amount of evidence from animal studies, from preclinical research, and from clinical studies, observational studies in population samples, that inflammation is strongly linked with depression, and that inflammation can produce, can elicit depressive symptoms if you produce some kind of exogenous inflammation. So we asked the question of, does pre-pandemic systemic inflammation predict heightened depressive symptoms during the pandemic? And so we looked at data from the English Longitudinal Study of Aging. We looked both at CRP and also at fibrinogen, but I'll talk about CRP. They were measured in the years before the pandemic, and then we were looking at the depressive symptoms during the pandemic period, adjusting for pre-pandemic depressive symptoms, as well as various other factors as well. So this slide shows results of this particular analysis, and what it's showing is the odds of high depression for people who had elevated CRP in the years before the pandemic, adjusting for these other factors. So what you can see in model 1 is that the odds of having high depression during the pandemic were elevated among people who had raised CRP levels, even though we're controlling for pre-pandemic depression. This odds ratio 1.69 is fairly respectable in this kind of literature. And then model 2 is adjusting for other factors which could be contributing to these associations, such as health behaviors, long-standing illness, and socioeconomic factors. And again, the association remains quite strong. So this does suggest that the diathesis of pre-pandemic inflammation might have been enhancing or exaggerating the impact, augmenting the impact of the pandemic on mental health. Our second analysis I'd just like briefly to show you was being a bit more kind of sophisticated in a way, and looking both at kind of psychosocial sort of factors as well as biological factors as potential risk factors for having negative emotional responses during the pandemic. And in this analysis, we were particularly interested in adverse childhood experiences and also pre-pandemic cortisol levels. So the adverse childhood experiences are assessed with a life history interview. And then we were measuring pre-pandemic cortisol using hair cortisol. So this is analysis of a rather smaller number of participants because we didn't have hair samples for everyone. So hair cortisol was assessed in 2012. So, 8 years before the pandemic. The childhood experience is also retrospective. And then what we're looking at is depression and anxiety during the pandemic. And you can see there the statistical methods we used a linear mixed models here, and we were adjusting, of course, for the pre-pandemic levels of the outcomes, that's depression and anxiety, along with sociodemographics, And we're also adjusting for childhood socioeconomic status, because we wanted to look particularly at adverse childhood experiences, such as separation from parents and those kind of living with parents with or with families with serious mental health problems, those sorts of things, independently of the child's socioeconomic status. And then we were also adjusting for medications and also for hair treatments, because obviously some people dye their hair and bleach their hair and all that sort of thing. So quite a lot of different results from this study, but the two which I think are quite interesting are the interactions between cortisol levels and adverse childhood experiences. So that's shown in this slide here. On the left-hand side are depression levels, and the right-hand side are anxiety levels. And the horizontal axis is the hair cortisol level. And so what is shown is the proportion of people who are experiencing, reporting elevated levels of depressive symptoms and elevated levels of anxiety symptoms in relation to hair cortisol, and also in relation to number of adverse childhood experiences. So the red lines are those people who had reported no adverse childhood experience, where there's a very small association between hair cortisol and depression during the pandemic, and no, or if even a kind of negative association for anxiety, whereas the green line are people who are reporting 2 or more adverse childhood experiences. And there you can see this quite striking association. So among those people who had adverse childhood experience, having higher levels of pre-pandemic cortisol seem to be associated with increased risk of mental ill health. And the blue line is the kind of intermediate pattern. So I think this is quite interesting in showing the way in which the individual differences in how people reacted during the pandemic might be associated with earlier characteristics. So could be the data we collected during the pandemic could be used to try to look at these kind of interactions and look at individual differences in how people respond. Okay, the last issue I wanted to cover, and I hope I'm not moving around too much across different points, is the issue of resilience and living a worthwhile life during the pandemic. And there's some analyses that we've been doing in this area, and they're proceeding very slowly. So I haven't yet published anything in this area. But what it derives from is some work that I did with my colleague Daisy Fancourt a few years ago about what we're calling leading a meaningful life at older ages, where we were looking at the associations in the English longitudinal study of aging between ratings of doing worthwhile things in life, which is a kind of indication of the extent to which people are trying to do things which they find meaningful, and their relationships with multiple outcomes. So in the first paper, we were looking at a whole range of different outcomes, both cross-section and longitudinally. And then in the second study in scientific reports, we were looking at bidirectional associations. So it was our feeling that this kind of measure of the extent to which people feel they're doing worthwhile things in their life is something which has some currency in terms of eudaimonic well-being and how that might be operating. And so I was interested in how this might relate to what happens during the pandemic. Well, here to begin with are the average ratings of worthwhile ratings in the pre-COVID period, that's in 2018, 2019, then in June, July of 2020, and then later in the pandemic, 2020, November, December 2020. This is a scale going from 0 to 10. And so what you can see here is that during the pandemic, on average, ratings of doing worthwhile things tended to decline. They declined a bit more among women than men, which is kind of consistent with some of the other measures I've been talking about. So there are two things we tried to do with this. First is to ask the question whether there are particular groups who preserve the sense that they were doing worthwhile and meaningful things during the pandemic, and whether we could characterize those. So we were thinking about the sorts of features of those groups which might be relevant, and two which particularly emerged, I think, quite strikingly. first of all, was what we call in this country key worker status, but in the US, I think is known as essential worker status. So this is a comparison between those people who were key workers or essential workers, so they were doing things that were continuing during the pandemic. Some people working in healthcare, but they were also working in transportation, they were working in food processing, food delivery, those sorts of jobs. And what you can see here are the levels of doing worthwhile things among those people who are key workers and not key workers, with a kind of preservation of the sense that you're doing worthwhile things during the COVID period for those people who are key workers or essential workers, whereas that tended to decline among the individuals who are not key workers. And we're adjusting here for several factors, as you can see on the slide. The second aspect, which seemed to be relevant, which is particularly relevant, I think, for older period people, was volunteering. This slide here shows three groups of people. First of all, in the blue are the people who didn't volunteer beforehand and continued not to volunteer during the pandemic. They have the lower levels of worthwhile ratings. And then there are two groups of volunteers, but some people's volunteering stopped, probably because they were not able to go out and do the things that they were previously doing. And so that stopped, whereas for other people, they were able to continue with their volunteering. And again, these are significant interactions here. So the people who continued with their volunteering tended to preserve the sense that they were doing meaningful things in their lives. The second issue that we wanted to study here was to ask the question of whether the preservation of sense of doing meaningful things early in the pandemic, so in June and July of 2020, related to emotional well-being at a later date. So was it a kind of protective thing which might be protective of a later emotional distress, even when we take account of the earlier emotional distress? So this is an analysis of the emotional well-being measures late in 2020 in relation to worthwhile ratings early in the pandemic. So the exposure here, if you like, are the changes in worthwhile ratings between pre-pandemic and early in the pandemic, whether people increased, stayed the same, or decreased in the sense they were doing worthwhile things. And the outcomes here, depression, anxiety, positive well-being, but I'll just show you the depression and anxiety measures here. And I think it's quite interesting that there were these associations were seen. So on top left, you can see depression using the CESD, the proportion of people scoring above threshold on the CESD. On the bottom right are the anxiety measures. These are means on the GAD-7. And in each case here, I divided the sample out into three categories. Those people who showed no change in their worthwhile rate, sense they were doing worthwhile things between pre-pandemic and pandemic. Those people whose worthwhile ratings actually improved, they actually went higher, and those people, which is more the modal response, where those ratings declined. And what you can see is that later on in the pandemic, the people whose sense they were doing worthwhile things declined, had higher levels of depression, higher levels of anxiety, adjusting for all sorts of other things, including the mental health early on in the pandemic. So I think this aspect of eudaimonic well-being may be important, I think, and interesting to look at it in relation to more hedonic measures such as depression and anxiety, and seems to be part of the way in which, at least for some people, the sense that they could preserve that feeling that they had meaning was related to better mental health and better adjustment at a later stage. So I'll stop there. I've covered a lot of different issues here, and I hope it hasn't been too rapid, but I think the pandemic has been very interesting and important, obviously in public health terms, but also for psychologists and for epidemiologists working on multiple issues. And I think it's been important in itself, but also can be used to some extent to think about some other aspects of people's experience. So I'd just like to finish by acknowledging my various collaborators on the different studies which I've talked about here. most notably my collaborator Daisy Fancourt, and working on the COVID social study, and Paolo Zaninotto, who's an important person in the English longitudinal study of aging, plus the funders, of course, including NIA and various UK funders. And with that, thank you very much indeed, and I'll stop sharing and see if there are any questions or comments people have.
Wonderful. Thank you, Andrew, for that very stimulating presentation on a very number of issues to do with COVID. So we have time for questions. Those who are in attendance who have questions, I invite you to drop those questions in the chat, or if you feel comfortable to just raise your virtual hand and I'll call on you. But I may, if I will, take this opportunity as host to ask a couple of questions. So I'm really fascinated, Andrew, by this puzzle of social isolation and loneliness during the pandemic, namely that although we see this increase in these experiences from prior to the pandemic, throughout the pandemic, that increase is not as pronounced as you might have anticipated. And on the one hand, you could say that this is just another example of resilience, right? This sort of modal pattern that you spoke to earlier. But on the other, it could be, and you sort of you touched on this in your remarks, that there are aspects of the pandemic, social aspects of the pandemic that may be unique, that may not be as salient during normal times. And one that occurs to me is just how much people spend time socializing online. And so I'm curious about your thoughts on how much social experience, we as social scientists are missing out when we are relying on, these measures of social connection that predate social media. And so do you think, these kinds of measures, such as, how much you spend time online with friends and family, should be included in standard measures of social connection, or should we be viewing these measures with skepticism, given some of the selection effects you mentioned earlier, and given the fact that technology is changing all the time?
Well, we have actually, in our own work on social isolation, which I haven't really spoken about, we've always included online connection as well as face-to-face contact. And so we've used a measure, I think is whether or not people have communicated by email or some other electronic form of communication every month or so as an indicator, or every week for some analyses indicated they were socially connected. So I think it's definitely part of the whole story, or by telephone as well. And clearly during the pandemic, there were, this was an important lifeline for people's social communication. In fact, I haven't spoken today, but we did publish a paper last year showing that on average, in fact, in ELSA, we didn't see a very striking increase in use of internet or use of email and voice, other types of communication like Zoom and Teams and things like that, which surprised me. I thought there would be more of that, but it wasn't a huge difference. I mean, there were some differences, but the overall internet use didn't go up as much as I expected, and I think that was in part, I suspect, to do with where people are able to use the internet, because clearly for some people they're able to do it at home, but quite a lot of people aren't able to do it at home. They tend to do that when they're at work, or they may have to use some public place, an internet cafe or a library or something like that in this country, and so that might have offset the benefits of doing that. But in general, you're absolutely right that I think our measures of things like isolation and social contact really have to take this into account in a much bigger way. And I think we're well behind the curve as well in terms of, we've managed to include things like email and stuff, but we're not, and WhatsApp, but we don't actually include some of the other methods of communicating that people have now.
Excellent. So I have just a related question with respect to your long COVID data. Given that there is this well-established literature linking, social connection to upper respiratory, illnesses, recovery from upper respiratory illnesses. I'm wondering if you have thought about that in relation to your long COVID data, namely, have you looked at pre-pandemic social connection, loneliness, social isolation, and so forth, and its association, if any, to long COVID?
I haven't done that, but I think that would be very interesting. I don't know if you've seen, there was a paper using the UK Biobank just recently showing links between isolation and hospitalization for infectious illness. So that, not to do with COVID, but in more general ways. So I think that that would be very interesting to do. That's a good idea. Haven't thought of doing that yet.
Excellent. So there are a couple of questions in the chat. I see James. Do you want to just unmic yourself and ask your question?
Sure. Yeah. No, first of all, thanks for this really fascinating. I won't say it's uplifting per se, but it's very inspiring talk. I think it is uplifting in some ways. I'm curious what you would say about what I'm calling metapsychological features. So thinking about the fact that you've survived something, or thinking about this last set of results you were presenting about maintaining meaningful activities. If you think I'm able to continue doing that through such a global experience of adversity, I'm just curious if you think how we would tackle measuring that, whether you think it's relevant.
Yeah, I think that's very interesting, and it's a major limitation of our data that we don't actually know what people are really focusing on, and so some people are going to be doing things which they could carry on doing because they whatever the activity was is something that they could continue to do. Maybe they're doing something at home that they were able then to focus more on than, maybe even more than they would normally do, because they had more time on their own. So that could be part of it, or it could be some aspects of caregiving, which is obviously a very meaningful activity which people were doing at home. So I think those kind of issues are really important, and maybe some people who might gain the sense of meaning and purpose in their life from work, that's going to be affected by for some people, because they weren't able to carry on doing that, whereas other people could. So I think there's some there definitely are some interesting aspects there that I wish we could look at in greater detail.
Excellent. I'm just looking to see if there are other questions in the chat here. Celine, I'm sorry, did you raise your hand? Yeah, please.
Yes, so thank you so much for your talk. I still have not really articulated my question in my head well, so bear with me. But I do want to, if I understand it correctly, and if I recall the findings correctly, in this in your COVID-19 study and response to the stressful events in the environment, I recall that the genetic risk for depression wasn't really predictive of these responses, at least in your sample. So I'm trying to understand, or I'm wondering what you think about how these genetic vulnerabilities to depression, in what psychological or environmental context you see may be more useful to consider.
Yes, well, I think you're talking about that. I didn't mention the work we did on genetic side of things, but in the analysis we did of adverse childhood experiences and cortisol, we were also looking at polygenic risk scores for depression and anxiety, and those were not predictive of the responses during the pandemic. Now, I think that the thing to remember is that we were actually looking, in a sense, for adjusted effects once we'd taken account of pre-pandemic levels. So it's not that those genetic risk factors weren't relevant to mental health. It's that they didn't predict the additional depression or anxiety which occurred during the pandemic. So, as it were, they may already have had their action on the baseline levels of the pre-pandemic levels of depression and anxiety, and so they weren't then predicting an augmented response here, which I think is not, in a way, is not too surprising in a sense, because those genetic risk scores tend to be almost defined by their relationship with the phenotype, which is present in the kind of pre-pandemic period, and the extent to which people might be vulnerable to challenge under specific conditions could well have a different genetic underpinning than that for the basic phenotype. I think that would be something which would be very interesting to look at.
Okay, thank you.
Great, thank you. Just checking to see if there are any questions. So maybe I'll just end by asking a question that relates, Andrew, to your last point about resilience, or somewhat related, which is, you hear this anecdote about people living their best life, so to speak, during the pandemic. And so this is slightly different from this issue of resilience, which has to do with, preservation of well-being, and more to do with enhancement of well-being as a result of the pandemic. I wonder if you've thought about that, if you looked at that in your data, in terms of your latent class analyses demonstrating, in this case, not so much changes in ill-being, so to speak, pre to post or pre to during, but rather increases in well-being.
Yes, I think that's something we would like to look at more than we have so far. I mean, it's difficult to recall back, but in the early parts of the pandemic, certainly in this country, people were quite enjoying themselves, so long as they weren't actually had an infection in their household, because they didn't have to go to work, and there were few responsibilities, and so people could actually spend more time kind of doing what they wanted to do. So to some extent, it seemed like an extended vacation for a couple of months, and it was only later on when the realization came that this was not just going to be a transient thing, but would go on and on, that the stress levels came higher. And so that's why I think in our data, for older people, the things like depression just got worse over the year, having been so I think that there were definitely opportunities early on with changes in balance of what people were doing in their lives. And I think to some extent that's obviously persisting, and the most striking way it's persisting is the way in which so many people now are working more from home than they ever did before, and that it's kind of more socially acceptable to do that. Instead of trying to sneak away from work, you're actually sort of almost allowed to stay away from work. And so people are then adjusting their lives to enhance other aspects and prioritize different things, which I think is going to be a legacy probably of the pandemic. Certainly in this country, we now have to, when we're advertising for jobs, we have to tell people how many days they're expected to work in the office and that sort of thing. So and I certainly have people who I only see once a week. So there's a lot more of that than there used to be.
Great, wonderful. Well, with that, I want to thank our speaker today, Andrew. Thank you for joining us and sharing with us your expertise and insights. And sorry if we kept you a little longer.
No, it's okay.
Close to dinner time there, but thank you again, and thank you everyone for joining us. And we'll see you actually next week for our next seminar speaker. Thank you.
Thanks, Anthony, for asking me. Okay, bye now.